Indications for performing the FAST or eFAST exam include blunt or penetrating chest trauma and blunt or penetrating abdominal trauma. Physical exam for the detection of internal hemorrhage is unreliable in the multiply injured trauma patient, and that's why the eFAST exam has become so popular. Study goals of the eFAST exam include the detection of Hemoperitoneum, the detection of Hemopericardium, and the detection of a pneumothorax. To be clear, the FAST exam is designed for the detection of Hemoperitoneum and Hemopericardium. The eFAST or extended FAST exam includes thoracic windows that allows for the detection of a pneumothorax. When performing the eFAST exam, it's important to look at your practice environment. Somebody who would be practicing in this environment that had no OR availability or immediate accessibility to other imaging modalities could potentially perform the eFAST exam a little bit differently than somebody working in a fully equipped trauma center with immediate availability to the operating room. With the eFAST exam, you've got multiple sonographic windows. From the standpoint of the detection of hemopericardium, you've got one pericardial window, which is a subxiphoid window. You have three intra-abdominal windows. You have a perihepatic window, a pelvic window, and a perisplenic window. If you add in the extended windows, which is part of the eFAST exam, you've got two thoracic windows for the detection of a pneumothorax. To master the FAST exam, you need to know what free fluid looks like on ultrasound and where it's going to be located. Free fluid will either be anechoic, meaning a black area, or it will be echogenic. The most common sonographic appearance of acute hemorrhage is going to be anechoic. However, as clotting occurs, you're going to start seeing echoes within that fluid, and how quickly these echoes appear is going to depend on the rate of hemorrhage. It's not uncommon to see echogenic fluid in someone with acute hemorrhage. So you have to be very careful here and not just look for a blackened area if you're looking for free fluid. You've got to be aware that the fluid very early on, particularly in contained areas like the pericardial sac or in the subphrenic space around the spleen or in the cul-de-sac in the pelvis, could be echogenic very early on, and novice scanners will look past these echogenic fluid collections because they've got their mind trained that they're looking for something black. So be very careful not to make that mistake. Here we have two patients, both of whom had penetrating cardiac injuries and both of whom had hemopericardium. The patient on the left here has a large echogenic pericardial fluid collection, while the patient on the right had an anechoic pericardial fluid collection. So remember, you have to be able to recognize both echogenic and anechoic fluid collections. Here are two different patients, both of whom had large collections of Hemoperitoneum, both of which were complex in appearance. Here you can see in this right upper quadrant view right here that the patient has a echogenic fluid collection between the liver and the kidney, and you can see it here in the subcapsular region up in here, and you can see the sharp triangular corners that the fluid has as it butts up against other structures. You can see the same thing over here. Here's the patient with a large fluid collection in the right upper quadrant. You can see the gallbladder coming in intermittently. Here it was again a second ago. But you can see this complex fluid here between the liver and the kidney. Notice here you've got the gallbladder. It has an echogenic wall around it, and it's got a nice oval shape with rounded corners. Note that the free fluid does not have a wall around it, and it has sharp triangular corners as it butts up against other structures. This is very common with free fluid and something that you want to be able to recognize. Let's take a look now at where free fluid is going to be located in both the chest and in the abdomen. Before we look at some ultrasound examples, let me just use a simple example here. If I were to ask you in both of these examples here, which container has the red fluid, on the left you would identify the red color, and then based on the shape you would identify which container has the red fluid. On the left here you would be able to say that it was a triangular container, and on the right here you would be able to say that it was in the rectangular shaped container. So keep this in mind as we're going through the rest of this lecture and as you continue to perform more and more FAST exams, that fluid is formless and shapeless, and it's going to have to take the shape of the container that it's in. When looking for hemopericardium, it's going to be a little bit more straightforward than in terms of looking for hemoperitoneum, because the pericardial sac is well defined and localized around the heart. Here you can see on this CAT scan image that the patient has a very large pericardial effusion, but you can see that it's easily identifiable between the parietal and visceral layers of the pericardium on the different views here. Now, looking for fluid in the abdomen is going to be a little more challenging, and it's going to depend on multiple factors, including the source of hemorrhage, the rate of hemorrhage, the patient's position, and whether or not they've had prior abdominal surgeries and potentially intraperitoneal adhesions. Looking at a patient with a hepatic source of hemorrhage, fluid is going to first go into Morison's pouch, which is the space between the liver and the kidney. Once that space is filled up, fluid is preferentially going to go up and down the right pericolic gutter because it's going to go to the area of least resistance, and it's going to head down into the pelvis. It could potentially go across the lesser sac into the left upper quadrant, but there's higher resistance here, so preferentially it's going to go up and down the right pericolic gutter. Now, in a patient with splenic hemorrhage, there's a couple things to consider. One is that in approximately 90% of patients, there's going to be a phrenicocholic ligament that's going to prevent fluid from going up and down the left pericolic gutter. Another consideration is that the left pericolic gutter is more shallow and under higher pressure, so it's not an area of low resistance. So even if the patient doesn't have a phrenicocholic ligament, fluid is not preferentially going to go in this direction. Fluid is going to go across the lesser sac to the right upper quadrant. But if you look here, the vast majority of fluid initially is going to get pulled into the subdiaphragmatic space. And that's because as the patient takes in a deep breath, you're going to decrease intrathoracic pressure but increase intra-abdominal pressure, and vice versa will happen when you exhale. So it's almost like a toilet plunger effect. Fluid is going to get pulled into that subphrenic space. And the reason I bring that up is that this is a key area to look for free fluid when you perform the perisplenic window. Yes, you can look in the splenorenal fossa, but it's important that you visualize that subphrenic space. So even if you forget most of this other, discussion on anatomic considerations, just remember to look in the subphrenic space, and to also remember that Morison's pouch is a key area for fluid localization, whether it's coming from the spleen, the liver, or even a pelvic source. So you can see here, once the subphrenic space fills, fluid is going to go across the lesser sac over to Morison's pouch and down into the pelvis. So let's begin our journey with the search for hemopericardium. We're going to begin by helping you gain an understanding of the subcostal window. In terms of patient positioning, the exam should be performed with the patient in the supine position. In terms of which transducer to use, any of these transducers would work. I prefer using a small footprinted transducer, either a curvilinear or phased array transducer. On adults, The frequency should be in the range of 2 to 5 megahertz to allow adequate penetration. While a large footprinted curvilinear array transducer would work, the FAST exam has 2 intercostal windows and 1 subcostal window. It's much easier to use a small footprinted transducer to fit into those spaces. An example of a subcostal window obtained using the phased array transducer, which has a small footprint and has beam steering, so you have a very wide sector image. It can fit into small areas and still provide you with a nice sector image. Here you have the liver and the 4-chamber view of the heart. Here is a pericardial window obtained using a small footprinted curvilinear array. Again, it provides a sector image here. You've got the liver here, and here's the heart with a echogenic pericardial effusion. But this would also provide you with a nice sector image and access into tight spaces such as the subxiphoid space and the intercostal spaces. Here we have a large footprinted curvilinear transducer. Again, it's going to provide a sector image, but you can see that the footprint on this is much larger. It's approximately 4 centimeters. So on this patient, it was able to provide us with a nice window and provide us with a nice subcostal view of the heart. But in some patients with smaller subxiphoid spaces, that 4 centimeter transducer may not fit as well. That's why I would advocate using a smaller footprinted transducer. Using this CAT scan slice, let me show you how the subcostal window is obtained. So you have the transducer on the abdominal wall in the subxiphoid space. The indicator is directed towards the patient's right, and you're shooting the beam in to the left hemithorax using the liver as a window, which will provide you with a 4-chamber view of the heart. When performing the subcostal window, you can be either in the abdominal mode or the cardiac mode. If you're in the abdominal mode, the indicator should be directed towards the patient's right so that you obtain the traditional image orientation. If you're in the cardiac mode, the indicator should be towards the patient's left in order to obtain the traditional imaging view. I would advocate performing the FAST exam in the abdominal mode, since you've got 3 abdominal windows and 1 cardiac window. Keep it in the abdominal mode, and when you do the subcostal window, have the indicator directed towards the patient's right. Remember, even in a thin patient, you're going to need a significant amount of penetration in order to obtain the 4-chamber view of the heart. When you're in the abdominal mode, most of the machines will boot up in their imaging presets to about 15 centimeters of penetration. I always advocate when performing the subcostal window that you give yourself at least 22 centimeters of depth. You can then always decrease the field of depth after you obtain the cardiac view. But in the beginning, I see novices struggling, unable to obtain the 4-chamber view because they don't have enough imaging depth. So remember, you're having to scan, even on a thin patient, through the liver into the chest in order to obtain this 4-chamber view. So make sure you have enough field of depth when doing this window. Here's a patient who is relatively thin, and you can see that 15 centimeters of penetration does not allow a good view of the 4 chambers of the heart. So make sure you give yourself enough field of view when performing this window. Let's break this window down into a step-by-step fashion, because I think that will make it clearer for you. First, begin with the transducer in the subxiphoid space in an AP plane with the indicator directed towards the patient's right. So that'll give you the following window: anterior, posterior, patient's right, patient's left. Use the liver as a window and find the inferior vena cava. You're going to end up following this into the chest and ultimately into your 4-chamber view of the heart. Is looking at the inferior vena cava important? We'll go into this more when we go into the echocardiography lectures, but the inferior vena cava can be evaluated very nicely with ultrasound, and it correlates well with CVP readings. So looking at the inferior vena cava that's less than 1.5 centimeters and has significant collapse with inspiration or sniffing goes along with a CVP in the 0 to 5 millimeters of mercury range. 1.5 to 2.5 centimeter diameter with approximately 50% collapse during inspiration goes along with a CVP reading of about 5 to 10. If you're at about the 1.5 to 2.5 centimeter range, but you have less collapse with inspiration, that would go along with a CVP reading of about 10 to 15. And if you have a plethoric dilated inferior vena cava greater than 2.5 centimeters with little respiratory variation, that would go along with a high CVP reading of 15 to 20. So there's a lot you can get from this window in a very quick amount of time. Now angle the transducer into the chest following the inferior vena cava. You can see here that you've got now the right, middle, and left hepatics visualized as they are draining into the inferior vena cava. Now as you continue to angle into the chest, you're going to get to the right Atrial-Caval junction. So at this point you're very close to getting your 4-chamber subxiphoid view of the heart. As you continue to flatten out the transducer and aim into the chest, now you're going to get your subxiphoid 4-chamber view. So again, here you are anterior and inferior on the abdominal wall. You're aiming posterior and superior into the chest. This is patient's right, this is patient's left. You can see here's the right ventricle, right atrium, left atrium, and left ventricle. You can see here that the hand is held on top of the transducer. You don't want to keep your hand underneath the transducer, since that will force you to basically bury your fist into the patient's abdomen in order to get this window. And patients who have either blunt or penetrating injury there are not going to appreciate that deep amount of pressure. Anything close to the diaphragm is going to be susceptible to respiration, for good or for bad. In this patient, when we started off, we did not have a good look at the heart. However, by having the patient take in a deep breath, we were now able to see a good 4-chamber view of the heart. Here you have right ventricle, right atrium, left atrium, and left ventricle. And here's the liver as a window. So remember, anything close to the diaphragm, see how respiration helps you or hinders you. In this case, having the patient take in a deep breath was beneficial for obtaining the good 4-chamber window. So in putting it all together, start in an AP position in the subxiphoid space, indicator to the patient's right, hand over the top of the transducer so you don't have to bury it into the abdominal wall, and then start angling. Follow the inferior vena cava until you get your 4-chamber view of the heart. Again, take note of the inferior vena cava since it does correlate well with CVP measurements, and we'll go through this more in the echo modules. But you can see that just by following the inferior vena cava in, you get a nice 4-chamber view of the heart. If you have to, have the patient take in a deep breath to improve the visualization of the window. So let's take a look at pericardial effusions now, and we'll start from large ones and work our way down to small ones. And you can see here you've got a patient with a large pericardial effusion, and you know that this is a pericardial effusion because it fits the shape of the container, and you can see that it is between the visceral and parietal layers of the pericardium, and it's circumferential around the heart. So this is easily diagnosable as a large pericardial effusion. Here's another example of a large pericardial effusion. You can see here's the liver as a window. Here's the right side of the heart with right atrium, right ventricle, left atrium, left ventricle. and you can see between the visceral and parietal layers of the pericardium, you can follow circumferentially this complex fluid collection around the heart. And here you can see the video clip. But again, this fits the shape of the container. It's between the two layers of the pericardium. Here's another large pericardial effusion. Remember, you got to consider echogenic effusions, and this patient has a large echogenic effusion between the visceral and parietal layers of the pericardium, and this was due to a penetrating cardiac injury. You can also see, although not part of the primary eval here, but there is basically no right ventricle visualized, and that's because of the presence of tamponade physiology. This patient has a very large complex fluid collection in the pericardial sac, and you know it's in the pericardial sac because it fits the shape of that container. But this is one that you could potentially miss if you go in there just looking for something that's black. Here we have a moderate echogenic pericardial effusion. Again, right ventricle, left atrium, right atrium. And here on the right side of the heart here, you can see between the parietal and visceral layers of the pericardium, you can see that there's an echogenic pericardial effusion. This was a patient who was stabbed in an attempted carjacking. Here's a patient who has a very small pericardial fluid collection. You can see it intermittently appearing, and it's predominantly seen on the right side. You can see it here. It's in between the visceral and parietal layers of the pericardium, but this is a patient that had a very small pericardial effusion. Again, the smaller the effusion, the more detail work you're going to have to do to define where it's at. So you're going to have to make sure that it fits the shape of the container and follows along the shape of the heart. So what's going to trip you up on this window? Basically anything that gives you an anechoic or echogenic space around the heart is a potential pitfall. Here's an example of a patient that has an epicardial fat pad. This is something that can confuse both the novice as well as the advanced scanner. If we take a look at the video clip here, you can see along the right side of the heart, what appears to be between the visceral and parietal layers of the pericardium, you have this echogenic space. But if you take a look at it closely, you can see that it has a fixed geographic pattern within it, almost a lattice-like appearance, and that's due to the presence of fat. This is different than what you would expect with free fluid or even clotted fluid, which would have a swirling appearance within it. This, you can see between systole and diastole, has a fixed appearance due to the fact that this is fat. So this is something you want to really take a look for on all the scans you do. Really appreciate these epicardial fat pads so that when you're in a situation where you've got to differentiate, is there fluid around the heart or isn't there, you've got that knowledge base because of the previous scans that you've done. Here's a comparison of an echogenic effusion with a fat pad. If you look here, here's a space along the right side of the heart, and you can see within there's an echogenic effusion, and you know that this is an effusion because if you look closely, you can see that the echoes don't have a fixed pattern to them, that they're swirling around, and that's because of the fact that this is clotted blood. However, if you take a look over here again and compare it to the fat pad, notice that these echoes within this space have a fixed pattern between systole and diastole. So where's the free fluid here? Here you've got the heart, you've got right side here, there's right ventricle, right atrium, left ventricle, and you can see that there's this anechoic space that comes around from the left and goes over towards the right. So based on the shape of this, this is a pericardial effusion. If you were to ever doubt whether or not something was a pericardial effusion, then your best bet at that point is to use additional echocardiographic windows, and we're going to go into those in greater depth during the echocardiography module. Let's go through this one and see where all the fluid is around the heart. So you see that there are some areas surrounding the heart that are either echogenic or anechoic. So let's take a look at areas in detail. If we look at the heart here, you've got right side of the heart here, you've got right ventricle, right atrium, left ventricle, left atrium here. You can see that between the parietal and visceral layers of the pericardium, there's a small amount of fluid seen here. You can see that it kind of tracks along over to the right side of the heart. Apical fat pads do not extend over towards the left side. So this is a pericardial effusion, but you can also see that there's some anechoic spacing right here, and this would be on the caudal side of the diaphragm. So this is a patient that also has free intra-abdominal fluid. In the medical patient, this could be ascites. In the trauma patient, obviously hemoperitoneum. But you can also see that there's a large anechoic space here along the left side of the heart, but this doesn't fit the shape of the container of the pericardial sac. This is actually a patient that had a large left-sided pleural effusion, and here you can see the lung, in this area right here. So this patient has pericardial effusion here, intra-abdominal or intraperitoneal free fluid, and a left pleural effusion. So there's different spaces in which fluid can be detected on this subcostal window, and you really have to look at what the shape of that container is that the fluid is within. Let's look now for Hemoperitoneum. The perihepatic window is going to be your workhorse intra-abdominal window, because remember, we had already talked during the anatomic section that regardless of the source, free fluid will have a tendency to go to this right upper quadrant region. So this is one that you're going to want to become very familiar with in terms of performing and interpreting. So this window is going to be performed with your curvilinear or phased array transducer. The transducer is going to be placed somewhere between the 8th and 11th ribs with the indicator directed towards the patient's axilla, meaning in a cephalad direction. You want to be in an oblique plane so that you're in the intercostal space. You do not want the transducer sitting on a rib, since you're not going to get sound penetration. And you're going to be somewhere at about the level of the mid-axillary line. And this is going to provide you with a window of the liver and the kidney, and then the space between there where free fluid should be localized. Using CAT scan reconstructions, you can see here how the images are obtained from an anatomic standpoint. So here you've got your transducer, indicator up towards the head. You're shooting in through the subcutaneous tissue. In between the ribs here, you're going to see liver, the space between the liver and the kidney, which is Morrison's pouch, and here's the kidney here. What's important to look at when we use an axial view of the abdomen, you can see that anything that provides a view of the liver and the kidney and the space in between is technically a perihepatic window. So you get a wide range of where you can place that transducer in order to get this image. You should also realize from this that if you just put the transducer on right away and quickly obtain a good image, all you've seen is a 1 millimeter slice into this whole space. So you just have to remember that. Since this is a window where fluid is frequently drawn towards, I will take a few extra seconds and sweep the transducer up and down and rotate it so that I get a good look at the entire right upper quadrant. So here we have, again, a better look at the perihepatic window. So here's your transducer. You can see that it's intercostal oblique, indicator closer towards the patient's axilla or head. And the image that you're going to get, here's the indicator here. So cephalad, caudal, lateral, because that's where the transducer is, over here, and your beam is shooting immediately. So here's subcutaneous tissue, here's liver, here's kidney, here's the true capsule of the kidney, this is perinephric fat right here, and this line that you have right here is a combination of Glissen's capsule and gyrotous fascia, so you're going to be looking for free fluid within here. Remember, the perinephric fat is going to be your defining border between fluid in the retroperitoneal space and fluid in the peritoneal space, and we'll go through this in future slides. So when you're doing the perihepatic window, identify the diaphragm. Fluid collections above that are going to be within the chest. Fluid collections below it are going to be in the abdominal region, or in the abdominal cavity. Look for the perinephric fat, because this is going to help you to differentiate intraperitoneal from retroperitoneal fluid collections. And take a look at the bowel. See how the fluid interacts with it, because this will also help you in determining the presence of free intraperitoneal fluid collections versus fluid contained, let's say, within the bowel. Here we have an example of a positive right upper quadrant window. So head, foot, lateral, medial. Here's the liver, here's the kidney, true capsule of the kidney, perinephric fat. So here you're going to have gyrotous fascia, and then this is going to be Glissen's capsule here surrounding the liver. So this is all Hemoperitoneum in between there. And you can see how it has that nice triangular shape here. There's no wall around it, and it's following along the course of the liver here and interacting with bowel over here. Here's why I advocate sweeping the transducer in the right upper quadrant. Let's say you put this transducer on and boom, this is the image that you get. Liver, kidney, perinephric fat, no free fluid. You can move on to the next window. However, by just sweeping the transducer and angling it a little bit, we go from negative to positive. So here's liver, free fluid, which is hemoperitoneum in this case, perinephric fat, and here's kidney. Now, in a potentially stable patient at a level 1 trauma center with full resources around you, who was going to get a CT anyway, the detection of this small amount of fluid may have had no clinical bearing. However, if you're at a non-trauma center where the detection of any hemoperitoneum means transferring the patient, or if you're in a disaster setting where you've got multiple people you're trying to triage, recognizing the presence of hemoperitoneum could help you in better triaging this patient. In this image here, you've got a patient who has both hemoperitoneum as well as hemoretroperitoneum. Again, you can see here's the liver, here's the kidney. You can see that there's a fluid collection here and a fluid collection here. So now you've got to look at boundaries to decide where this fluid collection is. You can see that this fluid collection abuts up against the liver, and it is on the opposite side of the perinephric fat. You can see that this fluid collection here is intimate with the perinephric fat and abuts up against the kidney. So this fluid collection is within the retroperitoneal space. This fluid collection here is in the peritoneal cavity. This was a patient who had a ruptured abdominal aortic aneurysm and had both hemoperitoneum and hemoretroperitoneum. While not a primary goal of the eFAST exam, it's possible that you may be able to detect solid organ injuries. And here you can see a patient on this perihepatic window. You've got the liver and the kidney here. The parenchyma should have, under normal circumstances, a nice homogeneous appearance. Here you can see that the liver has an area that is hyperechoic with irregular borders. This is in a patient with a hematoma to the liver. Liver parenchymal injuries will have a tendency to be hyperechoic. The sensitivity for the detection of solid organ injuries with ultrasound is very low, so if you don't see it, you haven't ruled it out. But if you do see it, this again may be helpful, since it's not uncommon for solid organ injuries to not be associated with hemoperitoneum. Here you can see in this patient that there is no associated hemoperitoneum, but the significance of being able to rapidly diagnose a parenchymal injury is clearly there. What are the pitfalls of the perihepatic window? First, it could be potentially hemothorax. It could be Hemoretroperitoneum, as we've already discussed. It could be fluid within bowel, or it could be a contained fluid collection such as a renal cyst. So anything that's going to provide you with an anechoic or hypoechoic space could be confused as a free fluid collection. So let's take a look at this case right here. Does this patient have Hemoperitoneum? Well, we can take a look. Here's the liver. Here's the kidney. We can see that there is a stripe here between the liver and the kidney. But now the question is it in the peritoneal space or is it somewhere else, such as the retroperitoneal space? If we take a look, we can try and define boundaries. Here we've got perinephric fat here. If we follow that along, we can see that the stripe, a thin stripe of fluid, is in between the perinephric fat and the kidney. So this would be a retroperitoneal fluid collection. This was a patient who had a grade 1 renal lac and had a small amount of hemoperitoneum surrounding the kidney. Here's one where you're scanning in the right upper quadrant and you see this large anechoic area, which catches your eye. So the first thing you should look at and determine is, does it fit the shape of the container, meaning the peritoneal cavity? And this clearly doesn't. This is a rounded structure with well-defined borders. So this is a contained fluid collection. And you can see that this fluid collection abuts up against the kidney. So this is actually a large renal cyst. And these are not uncommon to find during the performance of the FAST exam. So let's take a look at this patient. Does this patient have hemoperitoneum? So you're in the right upper quadrant. We can see here's the kidney. Here's something that looks like the liver, but it doesn't have a nice homogeneous appearance. So now you're going to have to define boundaries. Here you can see the perinephric fat here. Here you can see a rounded anechoic structure that would clearly not be free fluid, and it's within the renal pelvis there. So if we take a look above the perinephric fat and we look, we can see this heterogeneous area, but now we can see an anechoic area that has nice triangular shapes, is interacting with the bowel. So this is hemoperitoneum. And the area that we're seeing up here, this is the liver itself right here. This is all clotted blood surrounding the liver here. This was a patient who had massive hemoperitoneum and ultimately died. Let's now look at how to perform the pelvic window. Let's first take a look at a male patient. I'm only going to be looking at the sagittal pelvic window because I think this is the easiest way in order to determine free fluid in the pelvis. I think transverse images can be confusing. So to perform this window, indicator is going to be directed in a cephalad direction towards the patient's head. You're going to be just cephalad to the pubic symphysis. So your image is going to be anterior, posterior, head, foot. If the urinary bladder is full, you'll have a nice sonographic window. And you can see here is the peritoneal cavity. Here is going to be the cul-de-sac. This anechoic or hypoechoic area here, posterior to the bladder, the seminal vesicles. And this area here is the prostate. So you're going to be looking in this area here for the presence or absence of free fluid. If the urinary bladder is empty, then the exam frequently is going to be limited or indeterminate. In the female patient, again, we'll look at the sagittal window. Indicator is directed towards the patient's head. So anterior, posterior, head, foot. If the urinary bladder is full, you'll see it up in here. Here you can see the uterus, and this is going to be the posterior cul-de-sac. Up in here will be the anterior cul-de-sac. Using sagittal CT images, you can see how a positive image is going to appear. Here you've got a male, so you've got the indicator towards the patient's head. Here's the urinary bladder. Back here will be prostate to seminal vesicles. And here you can see the free fluid. Here's bowel right here, and this abuts up against the bladder and goes into the cul-de-sac. On this female patient, the urinary bladder is not full, but you can see here's the outline of the uterus, and here you can see a large amount of fluid displacing the bowel away, and you can see that there's the fluid in the posterior cul-de-sac extending into the anterior cul-de-sac. Sonographically in the male, this is what it's going to look like. Here you've got anterior, posterior, head and foot. You've got the urinary bladder. You know that this is urinary bladder here because it's got a nice round or oval shape to it and a well-defined wall. Prostate to seminal vesicles, and this is all free fluid here. And you can see how it's got the triangular corners, absence of a wall, and how it directly interacts with the bowel. So this was a patient who had a splenic laceration and had a large amount of fluid down in the pelvis. Here's a female patient with a large amount of free fluid in the pelvis. Again, looking at this sagittal image, you can see here is the urinary bladder, and you know this is a urinary bladder because it's got the echogenic wall surrounding it. It's got a well-defined rounded or oval shape to it. However, here you can see the uterus, and down here in the posterior cul-de-sac you can see the presence of free fluid coming over the top into the anterior cul-de-sac and then displacing bowel gas and directly interacting with it, and you can see the sharp triangular corners. So this was a patient who also had a splenic laceration and had a large amount of free fluid in the pelvis. Beware of clotted blood in the pelvis. This is an exam you're going to do looking for ruptured ectopics also, and it's very easy to look past clotted fluid trying to find anechoic fluid, and you're missing the very large complex fluid collections. So here's a patient that had a ruptured ectopic, and if you look here, you've got a couple anechoic areas here. So the question is, which one's a urinary bladder? This is actually the urinary bladder here. You've got the echogenic wall surrounding it here. It's got a nice contained shape to it. You could look at this one at first and say, boy, this has got to be the urinary bladder. But if you look, there's no wall up in here. And you can see how it's interacting with the surrounding structures. This is actually clotted blood in the anterior cul-de-sac, and this is all clotted blood posteriorly. So on females, it's particularly important when you see these kind of heterogeneous and complex areas, define the boundaries of the uterus, and that can then help you to decide what's surrounding it. And if you take a look at this clip here, you can see that was uterus. This is all free fluid here, clotted fluid. This is anechoic free fluid. And up in here is all just clotted blood. But this could be potentially easy to miss if all you're looking for is something black. In young females, you always got to consider that the free fluid you're going to see is physiologic. For it to be physiologic, it needs to be anechoic, and it would be very unlikely that the only place on the FAST exam that you're going to detect hemorrhage would be in the cul-de-sac. Usually people that are going to, or females that will have hepatic or splenic sources of hemorrhage will have some evidence of hemorrhage above the mesocolon, meaning that you would see it in the perisplenic or more likely the perihepatic window. But just keep in mind that very small amounts of anechoic fluid could be physiologic in young females. So does this patient have Hemoperitoneum? Let's take a look. This is a male patient. We'll take a look through the sweep here. Now if we start off, we try and find the urinary bladder. So this right here is the urinary bladder. It's got a wall and it's got a contained shape. You can see here is the prostate. Here are the seminal vesicles. So this here is the peritoneal cavity. You're really not seeing any bowel right there, but what you're seeing is a lot of echogenic fluid. There are some anechoic areas mixed in there, and you can see that there's nice sharp triangular corners. There's no wall surrounding it, and you can see that there's bowel moving up here that the fluid is interacting with. So this was a patient who had a grade 5 splenic lac with massive hemoperitoneum, and this is a large amount of complex fluid down in the pelvis. Here's a female patient who has a liver laceration. If you take a look at this window here, the first thing you want to do is to define things that you recognize. So here is what appears to be the uterus. There's the myometrium. Here's the endometrium. So you follow the border here. Now it seems anteriorly there's an anechoic area here, so you would think maybe this is the urinary bladder. But there is no wall abutting up against this side, and you can see that this anechoic area extends along here and over into here, and you can see that there's nice sharp triangular corners as this what turns out to be a large fluid collection abuts with the bowel. So this was a patient who had a very large amount of complex fluid down in the pelvis, and what originally could have been construed to be the bladder is actually not. The urinary bladder is down in here. So this is all free fluid, and there's bowel up in there. Take a look now at the perisplenic window. This is going to be obtained by placing the transducer between the 8th and 11th ribs with the indicator directed towards the patient's axilla, meaning in a cephalad direction. You want to be in the intercostal space. Since the spleen provides a smaller sonographic window, you're going to have to stay closer to the posterior axillary line. Using CT scans, here you can see what the image is going to look like. You get your transducer here, intercostally oblique, indicator up this way, and you're going to be shooting in through the intercostal space. Here's the spleen, here's the kidney, here's the splenorenal fossa, and here's the important subdiaphragmatic area that you need to see. If you take a look here, using this axial cut, you can see how you're going to be cutting through the spleen to obtain this window. What you want to be careful of is not being too far back and then angling anteriorly, because you're going to bring the stomach into view, which could be confusing, since frequently these patients have full stomachs, which could pose a diagnostic dilemma in terms of the presence or absence of free fluid. So here's your perisplenic window, indicator towards the head. You're cutting through in an intercostal oblique plane. So lateral, medial, head, foot, diaphragm, which is going to be a big landmark here. You've got your spleen here, your kidney here, splenorenal fossa, and here's the all-important subdiaphragmatic area. Here's a CT axial cut of a patient who had a very full stomach, and notice that if you're too far posteriorly angling anteriorly, you're going to bring the stomach into there, and this is going to then potentially give you visualization of a fluid collection that could potentially be overcalled and diagnosed as Hemoperitoneum. And here was a patient who had a very full stomach. On this perisplenic window, if you look, you can see spleen, kidney. There's nothing in the splenorenal fossa, nothing extending this way. But here you see this hypoechoic area that's very large, and it'd be very easy to want to call that a free fluid collection. However, if you take a closer look at it, you can see that there's some reverberation artifacts in there from air. You can see that there's a well-defined wall surrounding it. And if we look at it in a transverse plane here, you can see here's spleen, here's kidney, and here is the large fluid collection, which represents fluid in the stomach. Remember, you want to see the subdiaphragmatic space, since this is frequently where fluid is going to be. But depending on the patient's anatomy, the transducer you're using, it can be difficult to get a window into there. So remember, anything that's close to the diaphragm is either helped or hindered by respiration. Here's an area where taking in a deep breath is usually going to end up hurting you. you're going to usually get your best window when the patient's in exhalation. It's called the curtain effect here, because watch as the patient takes in a deep breath. Air comes over the top and basically this shows over. This is the air curtain that you have right here. So usually in these patients you're going to be better off with them in exhalation. So keep your hand on the freeze button so that you can cycle through their respiratory cycle and obtain the best image possible. So here's a patient with Hemoperitoneum. Here's the diaphragm here, here's the spleen. There's an anechoic area in between the diaphragm and the spleen, and this is Hemoperitoneum. You can see some air coming over the top from the costophrenic angle, intermittently interfering with visualization. But you can see here is some a moderate amount of fluid in this subphrenic space, so make sure you can visualize this area when performing the perisplenic window. Here's a large fluid collection. Here you've got diaphragm here. Here you've got a very large anechoic area. This is spleen, this is kidney. This is a patient who had a massive amount of hemoperitoneum. Anything that would be on this side of the diaphragm would represent fluid within the pleural space or a hemothorax, but this is all intraperitoneal here. You can see some fluid here in the splenorenal fossa, and you can also intermittently see fluid appearing within the stomach as the transducer is angled anteriorly, but this is all hemoperitoneum here. Here's a patient who has a left-sided hemothorax. There's no evidence of any intraperitoneal fluid, but you can see here's spleen, here's diaphragm, but this fluid collection is on the cephalad side of the diaphragm. You can see lung abutting up against the fluid here. You can see it down here in the costophrenic angle. And ultrasound is highly sensitive for the detection of pleural fluid collections. It can detect as little as 20 cc's of fluid, so it's a highly sensitive test. But when you're in the left upper quadrant, make sure that you visualize the diaphragm and don't misdiagnose a hemothorax as hemoperitoneum. Here's a patient that has a large subcapsular hematoma. You can see spleen here, and you can see this complex echogenic area surrounding the spleen. And this is all layered subcapsular hematoma. So there's parenchyma of the spleen, and this is all subcapsular hematoma and probably some parenchymal injury mixed in. It's really hard to define the border on these, but recognizing that there's a grossly heterogeneous or abnormal appearance is what's going to help you out at most in the beginning on these. Here's one when you look at it and ask yourself, does this patient have hemoperitoneum? You get yourself into the window where you can recognize the structures that you're trying to find, and here's spleen, here's kidney. I'm really not getting a good look at the diaphragm, but I don't definitively see anything in this point in the splenorenal fossa, but you're going to continue to look. Now all of a sudden you can see that there is something starting to appear in here, and you can see that it follows along the spleen. There's no wall around it. It extends down this way. So this patient does have hemoperitoneum. You're having a hard time really getting a good look at the subphrenic space, but something that should stand out is that just like with the liver, the parenchyma under normal circumstances should have a nice homogeneous appearance. This spleen has a very heterogeneous appearance, and splenic injuries can range from hypoechoic to isoechoic to hyperechoic. The sensitivity for detection is very poor, but if you see it, even in the absence of hemoperitoneum, this should help you in terms of triaging and understanding what potentials could go wrong with this patient. Here's a patient looking at the left upper quadrant window. First thing you want to define are things that you can recognize. Here's the diaphragm here, and here's this echogenic space here. Now you have to try and define the spleen. If you look, there's this area right here, and then there's this area that appears to be more gelatinous and it has a tendency to be moving. Let's see if I can get it to play again. And you can see that kind of moving there. This is all clotted blood on top of the spleen, and this is a massive amount of hemoperitoneum here in a patient with a grade 4 splenic injury. So what are the real clinical utilities of the FAST exam when you're looking for hemoperitoneum and hemopericardium? From a cardiac standpoint, operative management is going to be recommended if hemopericardium is detected regardless of the stability. These are people who will deteriorate very rapidly, so regardless of the size of the fluid collection or the hemodynamics, these are people who need emergent operative intervention. Does the negative pericardial window rule out a cardiac injury? No. There's no definitive literature on what to do with those patients, but at a minimum, serial exam is going to be warranted. How long that serial examination period would need to be is unknown. From the abdominal standpoint, operative management is going to be recommended if you got a moderate amount of hemoperitoneum and the patient's hemodynamically unstable. Hemoperitoneum in a stable patient, it's clearly recommended in the literature that these people undergo CT scanning to further define the injuries. How you do not want to use the FAST exam when you're trying to detect hemoperitoneum is to use it as a way to triage people out of the ED. Somebody who you feel is at high risk for intra-abdominal injury but has a negative FAST exam, if they're stable, they need to go and have further imaging, i.e. the CAT scan. Using ultrasound or the FAST exam to rule out intra-abdominal injury is going to get you into trouble and the patient into trouble. If you look at the study that was done in shock trauma years ago, they found that over a third of their patients who had splenic injuries and or liver injuries had no hemoperitoneum on the initial CAT scan. So being able to detect these solid organ injuries is very important. You're also going to be, you will also miss hollow viscous injuries when performing the FAST exam. So this should never be a test used to screen people out of the ED. Let's now look at how we can use the eFAST exam for the detection of a pneumothorax. Although most physicians in this country will use a linear transducer for the detection of a pneumothorax, you can use a curvilinear or a phased array transducer. So any of these will be usable for this study. This exam can be performed with the patient in any position, but in most critical patients, this exam will be performed with the patient in the supine position. Using Lichtenstein's classification, I will show Zone 1 and Zone 2. Zone 1 in the supine patient is going to be the most anterior or the least dependent portion of the thoracic cavity. Zone 2 is going to be the part of the thoracic cavity that extends from the mid-axillary line back to the posterior axillary line. We're not going to be discussing Zone 3 in this examination. And sonographically, what you're going to see, this is a sagittal exam with the indicator directed towards the patient's head. You've got the subcutaneous tissue here, pectoralis muscle. You always want to identify the ribs. That way you don't confuse a fascial line for the pleural line. And here you can see the pleural line here, and you can see the lung sliding back and forth, and you can see intermittent comet tails or ring downs emanating from the pleural line. Let's look now at the sonographic findings. Using the sagittal CT image of the chest, you can see here's a transducer and a sagittal plane indicator towards the head. You're scanning through the subcutaneous tissue. Here are ribs, and here's the pleural line. Here you can see that this is anterior, posterior, head and foot, subcutaneous tissue, rib, and then there is the hyperechoic pleural line. When evaluating the patient for a pneumothorax, you're really focusing on this pleural line. The primary thing you're looking for is the presence or absence of lung sliding. If you see lung sliding at this level, you can definitively rule out a pneumothorax at that level. The presence of B lines or comet-tail or ring downs are a secondary finding, but the main thing you're looking for is going to be the presence or absence of lung sliding. Now, it's important to remember you're not attempting to quantify the amount of lung sliding present. All you're really doing is looking for yes, no. Is there or isn't there lung sliding? So there's going to be different degrees of lung sliding in patients with severe obstructive lung disease, patients with pulmonary fibrosis, the patient who is hypoventilating. So you need to keep that in mind. It's an all or none. Do not confuse lung sliding with referred cardiac pulsation. Here was an image I obtained on myself during breath holding, and you can see that there is some movement back and forth, but this is due to referred cardiac pulsation and not lung sliding due to respiratory phase. How can you document lung sliding on a still image? You can use M mode or you can use Doppler. Here's an example here of two M mode images. One is in a normal lung and one is in a pneumothorax. If you look here at the normal lung, what you can see is there's a nice solid line here representative of what you would see on a, let's say, a barcode, and this is in the subcutaneous tissue where there is no movement occurring during respiration. However, when you look into the pleura, you can see that there's this gritty or sand-like appearance. Liechtenstein refers to this as the sandy beach sign or the seashore sign. This grainy appearance is due to the movement back and forth, and that could be used to confirm that yes, there was movement present. And since you don't see that same grittiness here or graininess in the subcutaneous tissue, you know that wasn't due to motion artifact. Now if you look here again, you can see solid lines here in the subcutaneous tissue, but now looking deep beyond the pleura, you can see that these lines have again a barcode type appearance, and that's due to the absence of lung sliding. So this is a way that you can confirm that motion was present or absent on a static image. So is lung sliding only going to be caused by a pneumothorax? No, there's many reasons why you could have absent lung sliding. It could be due to a pneumothorax, it could be due to apnea, complete atelectasis, massive fibrosis, or incorrect machine settings. Can lung slide be detected over pulmonary blebs? And the answer is absolutely. There have been several small studies that have looked at this, and here's an example of a patient with a large bleb. There was a question on the chest x-ray in this patient with respiratory distress as to whether or not there was a pneumothorax. A CT was recommended by radiology. Taking a look at the area directly over the pulmonary bleb, you can clearly see that there's lung sliding. You can see horizontal movement back and forth of the pleura. You can see some intermittent comet-tail or ring downs, but this was a patient who did not have a pneumothorax, and ultrasound was clearly helpful here. Now, pneumothorax is basically an air-only process at the pleural line. So you're going to have absence of lung sliding and a predominance of A lines, which are reverberation artifacts that occur from the distance from the soft tissue to the pleural line, and you can see those here. But taking a look at the pleural line, which you can clearly see is below the rib here, my transducer is moving, but there is no movement back and forth during respiration on this patient. So remember, absent lung sliding does not definitively diagnose a pneumothorax. In the right clinical context, it's highly suspicious for the diagnosis. So that leads to the question, is there a way that ultrasound could be used to definitively diagnose a pneumothorax? And the answer is yes. A lung point is a definitive sonographic finding of a pneumothorax. And here we've got a sagittal view here. Here's a rib. what you can see is that there's lung sliding with intermittent comet tails coming off posteriorly that extends up to about this point with respiration. However, from this side on over, there's absolutely no lung sliding. So this is sonographic evidence of where the opposed visceral and parietal layers of the pleura meet the pneumothorax. You would only see a lung point in someone who has a less than complete pneumothorax. Here's what it looks like when compared with a sagittal recon on a CT. Here's the transducer here, indicators towards the head. You can see here you've got opposed visceral and parietal layers of the pleura, and here you can see where the start of the pneumothorax is. This is a supine patient. This is the most anterior part of the thoracic cavity, which is where you would expect air to collect. And here's what you're seeing here. This matches what you're finding on the CT scan. You've got no pneumothorax here, pneumothorax here, and this is how it matches up against this CT scan. Just be careful when you're scanning by the border of the lung. This looks like a lung slide or a lung point here, that you've got lung sliding that stops right at about this point right here, but you can see that there is something that's moving right here, but it has a different echogenicity than this point right here. And it's difficult to see with a linear transducer because of the focused area of visualization. If you look at this same area with a phased array transducer, you can see that this is not a lung point, but we're down low by the border of the lung, and this is diaphragm here, and this is liver here. So this would be called a liver point, which is a pseudo-lung point. So be careful when you're by the periphery of the lung. Other things that could cause a pseudo-lung point would be, in addition to the liver point, a spleen point, meaning that you're on the left side and you're down very low near the diaphragm, or a heart point, where you're too close to the border of the heart medially. So how sensitive is ultrasound? The answer, it's highly sensitive. If you look at some of the studies that are out there, the sensitivity and specificity is in the upper 90s, which rivals CT scanning. Here was a patient that we had scanned prior to obtaining the CT scan, and what we noticed on this patient is that you've got lung sliding here to about this point, you've got lung sliding here to about this point, but in this central region you have absence of lung sliding, so you've got here a double lung point. So this was a patient who had a very tiny pneumothorax, and this is what we found on the CT, that this was only seen on one cut, and this is what we were looking at right here. So the bottom line is, if you can scan over the area and see the pleura, you have the ability to diagnose the tiniest of pneumothoraces. This means that this is a test that you've got to use in the context of your clinical exam. Not everybody who has evidence of a pneumothorax on ultrasound is going to need a chest tube. The same thing applies to a CT scan. Not everyone who has CT evidence of a pneumothorax is going to need a chest tube. So let me show you how powerful ultrasound is. Here's a patient who had a chest tube placed for a pneumothorax, and as we were reinflating the lung, we were doing some real-time clips, and what you can see is this patient was upright, and you can see as the lung was being re-expanded, you could follow real-time the presence of lung sliding, and we were able to follow this all the way up to the apex. So this shows you how powerful and sensitive this test is for determining the presence or absence of a pneumothorax. Ultimately, this test should be of great clinical use to you. You want it to be more than just a nice toy to say, boy, there's a pneumothorax present, but I don't know what to do with it. So as you become more proficient with this thoracic exam, you want to make sure that you can develop the skills necessary to estimate size. So the more of these exams you do and the better you become at them, what you're going to want to do is scan in more slices in zone 1 and zone 2, and then in your own mind recreate where sliding was present and where it wasn't, and you're going to be able to then have a better 3D image of the size of that pneumothorax. In one of Lichtenstein's studies, he found that in a supine patient who only had sonographic evidence of a pneumothorax, meaning a lung point anteriorly, which is the most anterior part of the chest in the supine patient, that these pneumothoraces are small and did not always need surgical intervention. However, in the supine patient, having sonographic evidence of a lung point in zone 2 or the dependent area meant that this was a moderate to large pneumothorax, and in these patients, in greater than 90% of them, they ultimately needed surgical intervention. So go past being able to just say yes or no. Try and use this in a useful fashion. Since this is a highly sensitive test, make sure that you can get an idea of size estimation so this test will be of utility for you.